Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCrae.
Tracy, after successful surgery, and I'm pleased to tell you that most surgeries are successful, the goal of most patients is to get out of the hospital as quickly as possible. I mean, you want to get home after your surgery.
Absolutely. To help patients achieve that goal, Mayo Clinic's Department of Colorectal Surgery is utilizing an innovative approach known as Enhanced Recovery After Surgery,
or ERAS. Some of the elements of ERAS include preoperative counseling, preemptive pain management, avoidance of opioid pain medications after the surgery, and getting moving again quickly, even walking on the first day of the operation or the first day after.
While this approach requires teamwork among surgeons, anesthesiologists, nursing staff, and the patient, it has proven to shorten the hospital stay and even increase patient satisfaction. Here to discuss enhanced recovery after surgery is Mayo Clinic colorectal surgeon Dr. Robert Cima. Welcome back to the program, Dr. Cima.
Thank you, Tracy. Thank you, Tom.
Dr. Cima, good to have you here. You know, I can remember the day when we would do a hip operation, hip replacement or knee replacement, and the patient would stay in the hospital 2 weeks. Doesn't happen anymore, does it?
No, not anymore. And in many respects, that's good for the patient. What we've known from a lot of information, a lot of studies, is the longer patients stay in the hospital, the higher their risks of complications. Because they're not doing what they normally do. They get exposed to things they don't normally need to be exposed to. And it's just one of those areas where getting home and getting back to your routine actually helps you.
You've talked in the past when you've been with us about all of the preoperative stuff that you can do to get ready for surgery, and that's part of this ERAS.
So ERAS is not something unique to Mayo, but it's something relatively new to the United States. It was started in Europe about 15 years ago, where a surgeon and a group of his colleagues felt that one of the things that was contributing to patients staying longer was not just because of the things we did to them, but also because of how we did it and the fact that some of the things we were doing sort of were counterproductive. So they took a whole different approach to looking at recovery and preparing the patient for the recovery and trying to do things that minimized disruption. So we weren't traditionally feeding patients right away. Well, what do you normally do? You eat. And so they started feeding patients the night of surgery. They started letting them drink rather than giving them IV fluids, because what would happen is oftentimes in the hospital, we would just give them a set amount, which is often too much, and then they'd feel all bloated and their body would sort of get overweight and things. Then they have to get rid of that fluid. So they just said, let's stop doing that. So there's a lot of little things we were doing that we thought were best, but when you put them all together, they were actually probably not the best approach.
And keeping patients in the hospital longer than they needed to stay.
And yeah, not only keeping them, but also forcing them to stay longer because we were now having to address the issues that we had done to them. So we'd have to get the fluid off of them, all that extra fluid we gave them.
I still can't get over that. You said a hip replacement, they'd be in for 2 weeks. How long is it now?
Oh, what, 2 days?
2 days, and in some places they're experimenting with day of surgery.
Oh.
So same day knee surgeries, where the patient will have the knee surgery and leave that evening.
Wow.
Yeah, and not just a meniscus removal, which is an outpatient procedure, but actually having the joint replaced. That seems a little quick to me. I think maybe one night wouldn't be too bad in the hospital. What do you tell the patients? I mean, do you counsel them before the surgery about what's going to happen and how you're going to try to get them out of the hospital quickly?
That's actually the most important goal, is to educate the patient and set expectations and inform them about what they're doing. As you know, a lot of our patients here at Mayo have had surgery before or have surgery by us before, and then they come back and I say, all right, we're going to do your intestinal surgery. I may have done something to them 5 years ago, 6 years ago, and I say, you're going to leave in 3 days. That's what we hope. And they're shocked because by last time, 3 days ago, they were just starting to eat. So patient education is key. Family education is key. Setting up the expectation that, yes, this is normal. This is what we want you to do. Those are essential elements of ERAS, patient education. If they're going to get a stoma or if they're going to need rehab, do that up front rather than when they're recovering from the surgery. Let them know what the plan is. We also very aggressively treat pain prior to surgery. Avoid systemic narcotics. put them on scheduled Tylenol, put them on scheduled Motrin, give them medicines before we even made an incision. So some of the things that we give for chronic pain patients, we'll give a single dose of that to modulate that pain. And what we find is patients waking up who they're reading the New York Times the night of surgery because we've set the expectations and we've worked with our anesthesiologists to set up a pain management program that they know about ahead of time and that is multimodality, so that we give them a spinal, we give them Tylenol, we give them ibuprofen, we avoid systemic narcotics, so that by the time they're ready to really start eating and taking oral pain medicines, they're already on board, they've already got their medicines ahead of the time, and they're ready to go.
Tell our listeners what you mean by systemic narcotics.
Well, a lot of patients are used to getting the IV pain pump, where you press a button and you get narcotics to relieve your pain. The problem with that is that when you give it IV, it affects every part of your body. Your brain, you get nauseous. All these other things are bad side effects from systemic narcotics. So now, as we've learned in multiple other areas of surgery, such as orthopedics, if you can give a regional narcotic or a regional painkiller to the area that's most affected, that you can avoid the use of those systemic narcotics.
So you're using a nerve block, instead of something that goes to the entire body.
Exactly.
It just goes to the region.
Just goes to the region. So not that we avoid narcotics, because they are a very important component of pain management, but we don't rely on them fully. So people say, well, Tylenol's not going to help. Well, Tylenol can help if you use it appropriately on a schedule, and you use it as part of a component of a multimodality pain management. So we use a block of narcotics, we use Tylenol, we use Motrin, and we use other agents to try and avoid the use of systemic narcotics, which have a lot of side effects.
And you indicated that it has helped shorten hospital stays, and that patients liked it. What are some of the patient comments that you hear?
The most important thing we hear is they're up moving around and they don't feel fuzzy. They don't feel sick. They have appropriate amount of discomfort from the surgery, but the other side effects that went with it, the tube in your nose, the things that weighed you down from getting up, those things are gone. And that's actually where they feel better. They actually feel like, I am up, I've had a procedure, but the rest of my experience is very similar to what I would experience when I'm at home. I eat, I sit up, I eat, I drink, I'm supposed to walk, I get up and walk, but I don't have a lot of tubes. I don't have a lot of drains. I'm not tied down to an IV pole. It's making them more having an experience where there's less foreign stuff involved.
And you find that less addictive type pain medications, not as strong type medications, work very well, especially if you start them before the surgical procedure.
Correct. It's not like we give you a prescription beforehand. When I say beforehand, it's the morning of surgery.
Okay.
We actually start in the pre-op area with medicines. And then when you go to the recovery area, the first thing, the nurse, once you're awake and able to swallow, she's going to put some Tylenol in front of you. So we're doing a lot of things to get that whole body inflammation to decrease.
I don't know how much you're into reading about the history of the Mayo Clinic brothers in surgery, but at our house we're reading that Mayo Clinic book, the Mayo Brothers book. And just to contrast what you're describing for patients and the surgical procedure as to what surgery was when Will and Charlie Mayo were doing it, doesn't even seem like we're talking about the same thing, because we're really not even.
We're not at all. The idea then, and up until just very recently, was you're having surgery that represents you're being sick. And I think the paradigm shift should be you're having surgery to treat a problem, and the surgery doesn't mean you're sick. The surgery is a tool to address your problem, and we need to accelerate your recovery from the surgery because we've done something to you.
Right. And there's nothing like getting home to mom.
Right.
Getting out of the hospital. Enhanced recovery after surgery, also known as ERAS. And we've learned about it from colorectal surgeon Dr. Robert Cima. Thanks for being here, Dr. Cima.
Thank you for having me.